All right, good morning, everyone. It's always a pleasure to hear from our trainees, especially our T32 trainees. Today, it's my distinct pleasure to introduce Dr. Pamela Alebna, who is currently a T32 cardiology fellow here at VCU. This program entails for her and many others so far 2 years of research training, followed by 2 years of development training.
Oh, excuse me, I'm so sorry to interrupt. Dr. Dahal is going first.
I'm sorry. Okay.
I'm so sorry. We discussed it right before you got on.
All right, sorry, Fadi, I'm gonna steal your thunder. Good morning, everybody. My name is Mo Makia, and welcome to another exciting cardiology ground rounds, where we have two amazing speakers of our fellows. I will introduce the first speaker, Dr. Suraj Dahal, who is a current cardiology fellow at VCU in the T32 research pathway. He did his residency in internal medicine from Icahn School of Medicine at Sinai in New York, and a research fellowship in coronary CT at Harbor UCLA Medical Center in California. He has a research experience on coronary artery calcification and coronary plaque quantification, and he has several publications in the field. During the T32 research year, Suraj has obtained a master's degree with major in biostatics from VCU School of Medicine. At VCU, he wants to study coronary atherosclerosis and breast cancer survivor, and he is the lead on the CT STAR study. Welcome, Suraj, and you can go ahead.
Okay. Thank you, Dr. Makia. Good morning, everyone. I would like to thank VCU Health for providing me this opportunity to talk about the very relevant topic, and also providing me the funding to conduct the study in women with breast cancer. So we're going to talk about utilizing coronary CT to detect atherosclerotic cardiovascular disease in women with breast cancer. We'll first talk about the introduction about why this is important to study in breast cancer, and how can we study CT, and why is it even important, or can we even do that? So the first slide here is the survival of breast cancer women since the time of diagnosis, and the blue line you can see here is the probability of surviving and breast cancer, probability of events, death from breast cancer related cause, whereas the yellow line is the probability of death from other causes other than the breast cancer, and majority of them are related to cardiovascular death. So we can see that the cancer related cause is actually lower than non-cancer related cause for death. So definitely we need to work on the cardiovascular cause or other causes to prevent mortality. So the treatment that we want to focus on our study is on survivors of breast cancer who are on hormone blockade therapy, namely tamoxifen and aromatase inhibitors. Tamoxifen blocks estrogen at the receptor, and aromatase inhibitor blocks endogenous production of estrogen in the fat cells, and they both change the lipid profile. So this is the change in lipid profile over time on patients with tamoxifen and aromatase inhibitor. I'll point you here the triglyceride, the first one, the dotted line says that the aromatase inhibitor, the tamoxifen increases the triglyceride, aromatase inhibitors also increases the triglycerides, and the LDL profile, tamoxifen seems to have lowering effect on LDL with time, whereas aromatase inhibitors kind of neutral to that, but it increases the total cholesterol. So there has been some change. It does change the lipid profile, and preferably in a wrong way. But tamoxifen lowers the LDL, so we don't know what exactly is happening in the clinical outcomes. And there is no randomized trial about these medicine about the cardiovascular death, whereas there's observational studies, major 2 studies here, which shows that there's no clinical difference among these inhibitors, hormonal blocker therapy and placebo on the survival. So we really don't know. We really don't know about it, and it changes the lipid profile, and maybe there is some change in the atherosclerosis, but then there may be some effect on the cardiovascular outcomes. We don't have good studies to show that. So our studies, we are using the CT to detect the atherosclerosis. So the major point here is, instead of focusing on the surrogate of the disease, which is LDL, HDL, and lipid panel, why don't we just focus on the disease itself, right? So why don't we just look at the coronaries directly and see what's happening there? And that's the whole point of utilizing CT, that we should move beyond our dependence on the biomarkers. This is a calcium scan, which is a CT scan of the chest gated with ECG, non-contrast. And we can see here there are lots of calcium in this 3-vessel. Looks like the first one is LED, the second is a ramus, and third is probably the high OM or a circumflex. Now, there are lots of calcium. Is this bad or is this good? Some people ask me, like, the calcium is protective, right? The calcium is a stable plaque, it's protective. Why it's bad? Or is it even bad? So there are still some doubts among people that, is calcium really bad? And I would like to show you the next slide, which answers this question. And it should be very clear that calcium is very bad. Having calcium in coronaries is bad. And this is from this study. And there are many studies after this, which we don't have time to go through all this, but this is, I chose this because this is the first one and major one in New England Journal 2008 by Ditrano et al. And I work in the same lab where he conducted this. So he was the MESA investigator, and 6,000 patients were followed up for 3.5 years. So there are 4 categories of calcium score here. The first yellow bar is a 0 calcium category. The second is people with calcium of 1 to 100. A third is 100 to 300, and the fourth one is more than 300 calcium score. So as you can see here, that the last bar, where patients have more than 300 calcium score, they have 14 times more hazard of having non-fatal MI and CSD death than those who have 0 calcium. And if you look at the 300 range, there are 10-folds increase. So it's clearly tells that having calcium is bad, and it's not just bad. There is like a exponential relation as the calcium progresses in the coronaries to have bad outcomes. So calcium, if you see on the coronaries in more than 40 years old, it's bad. Now, this is a paper from Dr. Hundley's publication. This says that in MESA, when patients with men or women who develop cancer, they have a risk of developing coronary artery calcium. So patients diagnosed cancer do develop calcium, and which is, I already told you that this is bad. So cancer diagnosis may lead to increased atherosclerosis, and that may be the cause of worse survival and cardiovascular mortality on these patients. So this is one interesting, just published a few months ago, and I added to my slide here because this is, I wanted to know this for a long time, and this is the paper published, and this is by Dr. Budov, my mentor. What he says is that, when does a calcium score equate to secondary prevention? So we know that having calcium, patients who have no events, calcium is a primary prevention marker. But if calcium is bad, and if there is an incremental worsening of the outcomes, there has to be some calcium score which should equate to, as a secondary prevention, equate to like somebody who already had an event, which should be treated like a secondary prevention. So what is that cutoff score? And they look in this registry analysis called a conformed registry, and the top mark, the top 2 lines there on the Kaplan-Meier curve is one. The yellow line is somebody who had the survival, the hazard of patients who had an event. So somebody who already had an ASCVD event, their survival curve over the period of years. And then the blue line, right, overlapping with that, the purple line, is somebody with calcium score of 300. So it looks like when somebody has a calcium score of 300, in the population who have calcium score of 300, their risk of having events over the next few years is the same as somebody who has an acute event already, who have an established ASCVD risk. So calcium score of 300 should be treated like as if they have a secondary prevention, not just like a primary prevention. This is another MESA paper, 2018, saying that what is the aspirin guidelines? Like, should we use aspirin based on calcium score? Because this has been always a doubt, always a confusion. I work in the clinic here, VCU, VA. There's always been confusion, like, should we do aspirin for primary prevention? Some people say with diabetes, yes, and then we did discontinue that. It's always confusion. So maybe this will help us to guide some of this confusion. There are three columns here, three categories: calcium score of 0, calcium score of 1 to 99, and calcium score of more than 100. The blue line, the blue bar, represents low ASCVD risk. We calculate this ASCVD, calculate the Framingham risk. Less than 10% CSD risk is the blue line, blue bar. The red means high Framingham risk, high ASCVD risk. But they both belong to calcium score of 0 here. And then there's a second category, and then there's the third category. So the red line here, horizontal line, is number needed to harm. And the vertical line, like 2000 here, we can see in the first bar, that means number needed to treat. So the blue bar in the first one, it says if patient has low ASCVD risk and calcium score of 0, the number needed to treat is 2000, and the number needed to harm is 500. So we should not treat with aspirin on these patients, because we are harming more than we are benefiting. Same with higher ASCVD risk, right? So if somebody has higher ASCVD risk, we wanted to treat aspirin for primary prevention, but it looks like if their calcium score is 0, then still we are harming them, because the number needed to treat is higher than number needed to harm. So calcium score is so powerful. They could have any risk factor, higher ASCVD risk. Still, if calcium is 0, they don't benefit from aspirin for primary prevention. As you move to the right side, the rightmost here, the calcium score of more than 100, the number needed to treat and number needed to harm, the high ASCVD and the low ASCVD, both these categories, the number needed to treat is lower than number needed to harm. What it tells is we can use aspirin for primary prevention, no matter if their ASCVD is lower or their ASCVD is higher. Doesn't matter. They benefit from primary prevention with aspirin. And this is an observational study, but it gives an idea of like when somebody's already on aspirin, should I discontinue? Should I start? So we can look at the calcium score and just get some idea. If they have high calcium, more than 100, let them be on aspirin for primary prevention, as long as they can tolerate it. This is from my own paper. Now, this is the reverse of what I talked about. If the calcium score is 0, what is the prevalence of obstructive coronary artery disease? And obstructive coronary disease can happen from non-calcified plaque, right? So we found here is that the prevalence of having obstructive disease in coronary CT, who's more than 70% stenosis, is actually less than 1%. So if calcium score is 0, the chance of finding an obstructive disease is less than 1%. Now, we still can find, so I've seen left main disease with non-calcified plaque with 70% stenosis with calcium score of 0, so we cannot 100% rely. And I tell everybody here, please, we should not rely on the stenosis severity with the calcium score. If somebody has no calcium, we cannot say that they have no stenosis. And somebody has high calcium doesn't mean they have severe stenosis. Calcium is a marker of risk. It's a risk predictor, not a stenosis predictor. But still, this paper, we looked at 4,000 patients, and which shows that the prevalence of having obstructive disease is still low, less than 1% if somebody has calcium score of 0. And this is one of the picture of a CT scan. What you can see is there the arrows are pointing towards non-calcified plaque. So there is no calcium sitting there. So it's a non-calcified plaque causing severe stenosis. But if you look at the above that, there is some calcium. And then this patient has calcium, but the calcified plaque is not causing obstructive disease here. It's less than 50%, but down there is obstructive disease. So calcium doesn't mean that there is obstruction there. Calcium, likely there is actually non-obstructive disease, but the patient has increased incidence of having obstructive disease or increased incidence of having MI in the future. So calcium is a risk predictor. This is a machine learning tool called a Clearly company established by Jim Min. He's the CEO. And what they use is like they use the AI-based techniques. And if we provide them the CT scans within minutes, 10, 15 minutes, they will provide us the data about the stenosis severity, the plaque burden, calcified plaque, non-calcified, the diameter, all the things that IVUS gives, and all the things we can manually do. The machine learning is doing that. It costs about $3,000 cash per patient. So it's not convenient right now, but it's coming. It's coming very soon, I think, in the future. This is an IVUS-based paper. Now, why baseline plaque is important? And this is, I chose this, it's not CT related, but because CT, we do the plaque quantification anyway, so this is important for that perspective. So this is a group of patients done by Stephen Nichols' team. So the baseline PAV is a percent atherema volume. So somebody with a baseline plaque, higher baseline plaque, had higher risk of having events in the future. Now, all these patients were treated with high intensity statins. So they have higher LDL to begin with, a lower LDL, high LDL, high risk, high percent atherema volume in the baseline. They treated with high intensity statin and then followed for 2 years and saw then like who have events, who do not have events. And what they found is if you treat patients with a high LDL, you can lower the events, right? Because we can see here the baseline LDL, if you treat with high intensity statin, they didn't have events here. But the percent atherema volume, even if you treat somebody with this category, if they have plaque to begin with, no matter if you treat with high intensity statin, they are still going to have an event. And this is the residual risk we talk about statin treated patients. So it is very important to identify these patients, good and bad. The good is because we can identify this patient. The bad is because even if we identify, looks like they are going to have an event. Even if we treat with statin. So we need like an aggressive treatment on these patients once we identify. In the next few minutes, I'm going to talk about some of my presentations and papers on this specialty. This is from a STOP trial in 2021. The STOP trial is still going, but this is a semaglutide and the study of coronary atherosclerosis, what semaglutide does. And this was the baseline study. So this is not, I'm not talking about semaglutide effect, but we had a baseline data and baseline CT. So what I looked at is, does hemoglobin A1C effect has any association with baseline coronary plaque burden? And what we find in with the CT quantified the plaque, and it looks like the A1C has no association with the baseline coronary plaque volume. And I'm not saying the A1C is not effective, but at least from this study, I didn't find any association. But the duration of diabetes had the association. So the longer the duration, the more the coronary atherosclerosis. And so we're still going to wait for the publication of this STOP trial. What semaglutide does to the coronary atherosclerosis. We still have to wait. This is another abstract presentation in AHA about the statins. So this is, we looked at the statin users and non-statin users. We looked at the baseline CT and a follow-up CT few years after. And what we find is that the plaque increases, whether patients take statins or patients do not take statins. The coronary atherosclerotic volume keeps going up. We cannot regress the progress. We cannot regress the plaque. But what statins does is it slows the rate of progression. So the rate of progression was significantly lower in statin user than among non-statin user. And the non-calcified plaque burden progression was significantly lower in statin users. And that gives a mechanistic effect of how statins work. This is AI-based technique I use. I just show you the slide with the machine learning. So I work with one of the papers with them, and we look at the gender difference from the credence study. So this how male and female are different in terms of coronary plaques, because we know they behave differently in symptoms, angina, outcomes. So what we find is that there was no difference between the plaque characteristics and plaque volume between male and female. And whether they have ischemia or not. Ischemia was by FFR, invasive FFR, less than 0.8 and more than 0.8, but there was no difference between the different plaque types between male and female. This is from the same one. We said the ischemic versus non-ischemic vessels. We look at the CT, quantified the plaque, and we found that ischemic vessels have significantly higher plaque than non-ischemic vessels. And it also gives some idea about why ischemia is bad, right? If ischemia prevents, if ischemia predicts outcomes, bad outcomes, maybe it's coming from higher atherosclerotic volume there. Higher atherosclerotic burden may not just be from ischemia. We don't know that. I'm not giving that hypothesis, but I'm saying that what we find is the ischemic vessels have significantly higher plaque types and positive remodeling than in vessels with non-ischemic. This is my first paper ever about review paper about the different modalities, treatment modalities, and a CT coronary and see that if what happens to the plaque. So statins slows the rate of progression, and Eliquis, Xarelto, Cilostazol, biologic agents, icosapent ethyl, Vasipa, all these reduces the plaque except for testosterone. There's a trial called a T trial or testosterone trial, which found that the male with hypogonadism, when they were treated with testosterone, actually increases the coronary atherosclerosis. So that's the only thing that I found which is increases, but otherwise these agents reduce the coronary plaque burden over time. And semaglutide is the one that we are waiting for the final paper. So if plaque burden is important, and if multivessel involvement is important, and stenosis severity is also important, why don't we come up with a staging system where we incorporate both these measures? So we incorporate the single vessel disease, multivessel disease, stenosis, as well as this coronary plaque burden. And then that can be a new classification. This was proposed by Freeman et al. And where it says the stage 0 is like no plaque burden, no stenosis. So stage 0. Stage 1 is there is a stenosis less than 50%, but there is increase in plaque like less than 250 millimeter cube. And as you go to the higher stage, these have higher amount of atherosclerosis, like more than 750 millimeter cube of plaque volume and more than 50% stenosis. So it does not just tell about stenosis, it tells about the stenosis can happen by like one single plaque. Whereas that same stenosis, there could be lots of atherosclerosis in the coronaries. So we need a new classification. And with this staging, they also proposed a treatment guide strategy. So stage 0, meaning no stenosis, no plaque. What they say is that shared decision making, like may not even need statins, even if they have high LDL. So here is the trick, right? Even if they have high LDL, this current guidelines say that if they do not have any atherosclerosis, why you want to treat them with statins? Instead, they propose to do a CT in every 4 years, and then see if the 4 years they develop plaque, then you start the treatment. If there's no plaque, you do another 4 years on the CT. But at the same time, if in higher stages, they want to be very aggressive. They want to add aspirin, rivaroxaban, colchicine, PCSK9 inhibitors as we go with higher stages, like higher percent atheroma volume in the coronaries, higher plaque burden. And then the follow-up will be every year or so to see if they are regressing in the plaque or if the plaque is still progressing. So it's very personalized. There's no LDL here. There's no other markers. It's very personal, individual treatment. So now coming back to my project and at VCU is that, okay, we learned about CT. We learned in the beginning about the cancer and the risk of having atherosclerosis and the cardiovascular mortality. So why don't we apply CT and use this technology and apply to our population here, breast cancer survivors who are on hormonal blockade therapy, because we know the hormonal blockage causes the lipid imbalance. So let's look at the coronaries. That is the whole purpose of our study here. And we have already started enrolling. We are almost like we have enrolled like 15 patients here. Our goal is to study 70 subjects, 35 who were treated with hormonal therapy, hormonal blockade therapy, and 35 controls who were not treated with hormone therapy. All of them have breast cancer. And this is a cross-sectional study, so single visit, one-time study. We will do a CT coronary, do a coronary calcium, and then we'll do the data analysis, and no follow-up is required. So this is like a one-time cross-sectional study. And this study is ongoing, and this is our trifold for the CT STARS study. And we are collaborating with the Massey Cancer Center and VCU Pauley Heart Center here. These are our study collaborators. I'd like to thank Dr. Makia is a PI, myself there, Dr. Hunley, Dr. Grizzard, Dr. Susan Hong, and Dr. Hackney from Massey, and Dr. Botner, and Dr. Bandyopadhyay, our study collaborators. Research coordinator Nicole Kisakire, she is excellent. She is actually running the show. I'm in the middle of the fellowship, and she is helping to recruit, consent, and she's really running the show here. And I'd like to thank Nicole for that. Fellows, our new T32 fellows are helping me on this project, Aditi and Pamela. And we have a resident in internal medicine, PGY1, Matthew Campbell, who is very interested and is also a part of our project. And with this, I would like to thank everybody. And I think that's the end of my slide. thank you. And if we have a few minutes, I can take some questions, or we can move to Pamela, and we can go from there.
Hey, Suraj, this is Gachoka.
Hi,
can you
David.
hear me? Hey,
Yeah.
hi. Yeah, I was just looking at those risk modification for or treatment for stage 4, right? It's so like on your last, right? Can you do you know how like colchicine would be useful in the treatment regimen?
Yeah, David. I think colchicine is back on the game, and I think it has anti-inflammatory and cardioprotective, especially like it will prevent the MI. I don't know about how the CT and has been used, but in that guideline that I proposed, the colchicine was added to stage 3. So if somebody has a very high atherosclerotic burden, we should not just lower the LDL less than 70 and be happy about it. I think we should go with colchicine or more like anticoagulation like Eliquis and rivaroxaban. But I think I'm not sure about that. Like, I think Pamela is going to talk about that anti-inflammatory actually.
Okay, thank you.
You're welcome.
There are a couple of questions in the chat. I'm not sure if you can see them, Dr. Dahal.
Yeah, I can see that. Yeah. Let me go with the first question. Okay, so this is by Dr. Lesnevsky from the VA. What do you think the effect of anthracyclines on CAD progression risk? Is there evidence of direct plaque injury? Yes, anthracyclines has been studied, and I think from the VCU Pauley Center, we are studying that. We know anthracyclines effect on the heart failure. I'm not sure about the CAD progression, and this will be nice to look at. When I looked at this before, I did not find any like significant papers about coronary artery disease. It was mostly with the effect of myocardial injury, heart failure, but it will be also interesting to look at what anthracycline does to but unfortunately, my study is only focusing on the hormonal blockade like tamoxifen or anthracycline, but I think that should be our another project. And Dr. Hunley asks the question here, what coronary CT measures will serve as outcomes in a study, and how will you account for potential confounders that may be present in either group enrolled in a study? Yeah, so this is a practical part from our study. We have to adjust for this confounder. So the CT measures will be twofold. One is a non-contrast studies of calcium scan. So first patient gets a calcium scan. So we're looking at a calcium score difference. Total calcium score in Agatston units between the control and cases. We can also go by per vessel, but generally it's a total score that has been studied in all the papers. So we'll go for total score. The second is we'll inject the contrast into a CT angio. Now, when you do a CT angio, we enter a different world because we can now characterize this plaque. We can look at the diameter stenosis. We can look at the type of plaques, the non-calcified, calcified, fibrous, fibrofatty plaques, all these, and high-risk plaque. And high-risk plaque has been shown to have adverse events like napkin ring sign, lipid core, and all the things. So we can do all these plaque markers and see if there's any difference between these cases and controls. And there will be a confounder, so we have to match. We have our protocol is we'll match. We'll do a group matching. We won't be doing one-to-one matching, but we'll do group matching. We have to match with statin use. We have to match with the stages of cancer, and also we have to match with aspirin use if they were using aspirin. So it will be challenging to find like an exact match, but we have a protocol to do group matching. Okay, 7:59. If there are no more questions, I would like to hand over to Pamela, and let me stop sharing.
Dr. Salim, if you'd like to go ahead and introduce.
Yes, yes, absolutely. My pleasure. Okay, so good morning again. It is my pleasure to introduce Dr. Pamela Alebna, who is currently a first-year T32 cardiology fellow at VCU. Dr. Alebna is originally from Ghana, where she completed her medical education at the University of Ghana Medical School. She then went on to obtain a master's degree in public health at the Harvard School of Public Health. After completing her graduate education, she started her internal medicine residency at Rutgers Health at Jersey City Medical Center in New Jersey before joining us at BCU last July. During residency, she led several quality improvement projects and was also the chief resident in her final year. Her research interests are mostly in preventive cardiology with a focus on lipoprotein (a) and inflammation. And I can't emphasize enough how fortunate and happy I am to have the privilege to work with Pamela. She's full of energy, very enthusiastic about research and cardiology training in general. So Dr. Alebna, take it away.
Thank you, Dr. Salim, for the very kind introduction, and thank you, Suraj, for the amazing presentation. And so I'm happy today to talk about lipoprotein (a) and its bidirectional relationship with inflammation. I have no disclosures, and these are my objectives for today. So I have three main ones, and then a few slides to go over my research project for the year. So the first is we'll be looking at an overview of lipoprotein (a) structure, its genetics, racial variations and trends, and then lipoprotein (a) and atherogenicity and how it relates to atherosclerotic cardiovascular diseases. And then the main thing for today, we'll be looking at LPA and its association with inflammation, mainly IL-6, oxidized phospholipids, and then the sterile inflammasomes. So our first objective. By way of introduction, I just wanted to give some basic facts about LP(a). So it was discovered in 1963 by the Norwegian geneticist Dr. Beck, and plasma levels we know are primarily about 70 to 90% determined by the LPA gene locus on chromosome 6. Adult levels are reached at approximately 8.5. That is when the gene is believed to be fully expressed. The rest by non-genetic influences on production and clearance. It has the most genetic influence of all lipid biomarkers. And that affords us the opportunity to be able to measure it in one person and by cascade testing, potentially identify family members who are also at risk. It's been shown to be a causal risk factor for ASCVD and calcific aortic stenosis. And the LPA gene is also believed to have evolved from remodeling of the plasminogen gene and is present only in humans, old world monkeys, and hedgehogs. We know 1 in 5 people have elevated levels. Accepted cutoff we know is 125 nanomoles per liter per the ACC/AHA. However, I want to add that from the other guidelines, like the Canadians, their cutoff is about 100, and the European Atherosclerotic Society, they actually have 3 levels, less than 30, 30 to 50, and more than 50. But it appears research now is accepting 125. Most of the papers coming out are accepting 125 as the cutoff going forward. And one thing about lipoprotein (a) is even though it's atherogenic and it's high in 1 out of 5 people, there are also individuals walking around with literally very low levels or undetectable levels, and they are completely fine. So we're still very unsure of its physiological role, even though we know it's very atherogenic. So I have here a schematic representation of the LPA molecule, just to show how closely it looks, it resembles LDL, and yet it's also very different. So here we have the core, the lipid core, the ApoB100 molecule, and then to that is attached the ApoA molecule. And on the right here, as I mentioned earlier, we'll probably be discussing later one property of LPA, which is it's being prothrombotic, and that's also believed to come to be from the fact that if you look at the plasminogen gene, it resembles, and the LPA is believed to have evolved from it, where it has these domains called kringles. So the plasminogen has kringle 1, 2, 3, 4, 5, and out of those, kringle 4 and 5 are found in the ApoA gene, and out of those, kringle 4 has 10 subtypes, and out of the 10 subtypes, kringle 2 of kringle 4-2 could have 1 copy in one individual and more than 40 copies in the next individual. And so for many years, this has posed the challenge in developing standard assays to measure LPA. LPA is also known to have significant racial variation. So persons of African ancestry. In almost all studies, cohorts, observational, all studies have shown that they have 2 to 3 times higher levels than other races. And this study here in 2022 actually showed that a specific proportional risk adjusted for covariates increases similarly with increasing LPA. So even though levels are higher in them, if you go up by a certain factor across races, your proportion, your risk proportion is equal. And then we have temporal trends of LPA, which is another feature. We know it's steady across the life course. However, in this study from the ARIC cohort, where they compared LPA in visit 4 to LPA in visit 5, and the good thing about these 2 visits was that the follow-up time was about 15 years. So you see the people in high levels, almost 100% of them stay high. And if you look at the green box, which is the individuals with low levels, again, almost 100% of them stay low. However, if you look at the borderline group, half of them become high and half of them stay borderline. And some of these non-genetic influences that we've seen are liver disease mainly can decrease LPA, and kidney diseases can potentially increase LPA. That said, it's still relatively stable across as you age. So this takes us to our objective 2, which is looking at its atherogenicity. LPA, this paper was released about 2 weeks ago in JACC. We've known it was very atherogenic, but on a per particle basis, nobody had really compared it to LDL. And these investigators looked at the fact that it has ApoB, and LDL also has ApoB. So if you look at the graph, they try to see the genetic effects on coronary heart disease risk, comparing the ApoB associated with LPA to the ApoB associated with LDL. And you can see here that on a per particle basis, LPA is actually about 6 times more atherogenic than LDL. However, we should interpret this with caution. And this was an editorial written on the same paper, where if you put the 2 on a balance, that's the diagram here, the balance and at the top. By virtue of the fact that LPA is more pro-inflammatory, it is smaller, it is anti-fibrinolytic, it appears to be more atherogenic. But in most people and almost in everybody, we know we have more LDL than we have LPA. So in the balance in the B, you can see in this example, they looked at an LPA concentration of 250 nanomoles compared to an LDL ApoB of 2,250 nanomoles. And because most patients would have larger numbers of LDL, their ASCVD risk tends to be higher for LDL. The balance will only shift to higher relative ASCVD risk for LPA as the plasma LPA levels increase and the LDL levels decline. So essentially, in a patient that you've treated the LDL very well, and in those patients, there could be a residual risk if their LPA is high.
The guidelines for how to manage.
So we will now delve into LPA and then inflammation. Like other ApoB particles, it can accumulate in foam cells. Like other LDL particles, we know it has the propensity to oxidize after entry into the vessel wall. And the exact mechanisms underlying the increased ASCVD risk mediated by LPA was not known. However, we now believe that there are signaling properties that can invoke an inflammatory response in different cell types. So we're going to look at 4 main ones, which is IL-6 and its effect on the promoter region of the LPA gene, circulating LPA oxidized phospholipids, arterial wall inflammation in persons with elevated LPA, and then the NRLP3 inflammasome. So IL-6, we know induces production of LPA. So IL-6 induces the synthesis of the ApoA component of LPA by triggering the promoter region of the LPA gene. So the LPA levels are increased in individuals with elevated serum IL-6. In this diagram here, I just wanted to show this is the LPA gene, and on the 5' end, you can see the promoter region, which is known to have IL-6 response element. So what essentially means is that if your IL-6 is raised for some other reason, some other inflammatory process, you could have acute upregulation of your ApoA synthesis, and that would mean more assembly of LPA particles and accumulation of oxidized phospholipids and increased inflammation. In most of the studies with IL-6 were done in rheumatoid arthritis patients, and you notice most of them, the ones with low IL-6 compared to those with high IL-6, the LPA levels were significantly higher in those with IL-6. And in studies looking at IL-6 inhibition on lipoprotein little a, also most of them in rheumatoid arthritis patients, you can see that as they inhibit IL-6 over time, lipoprotein little a levels went down. So now we look at LPA and oxidized phospholipids. Oxidized phospholipids are generated when phospholipid molecule undergo oxidation at sites of tissue stress. And LPA is the major lipoprotein carrier of oxidized phospholipids. The reason why there's a preferential sequestration of the oxidized phospholipids on LPA over other lipoproteins are mostly unknown, but we know this is the case. And in this paper in NEGM, when you look at a graded increase of CAD from no disease to 1 vessel, 2 vessel, 3 vessel disease, you can see your oxidized phospholipid bound to ApoB100, it's higher. And we know that most of this oxidized phospholipid in your blood is attached to lipoprotein little a. And it's the same for LPA. As your risk for CAD goes up, your LPA levels also go up. And now the NLRP3 inflammasomes, it's activated by various endogenous signals such as oxidized low density lipoprotein cholesterol and crystals. Oxidized phospholipids on LPA can be recognized as danger-associated molecular patterns called DAMPs on innate immune cells, and this could result in potent pro-inflammatory response. So if you look at and now this is just like a basic diagram of the whole steroid inflammasome. At the top where we have these are potential activating stimuli for steroid inflammation, where we could have microbes, insoluble matter, and DAMPs. And if we are saying that oxidized phospholipid is one of these DAMPs, and we know that in plasma, most of your phosphoride oxolipid is bound to LPA, then in persons with high LPA or specifically high LPA, and that has more oxidized phospholipids, then they can potentially induce the steroid inflammasome compared to someone who would not have high LPA. Lipoprotein little a is also shown to induce arterial wall inflammation. In this study in circulation, they compared 30 subjects with normal LPA to 30 with abnormal, where the mean for normal was 7 and abnormal was 108. And there was an enhanced peripheral blood mononuclear cells trafficking to the arterial wall in subjects with high lipoprotein little a. So if you look at the top diagram, these are images demonstrating increased FDG uptake in normal LPA versus elevated LPA, and they quantify this as maximum target to background ratio, and then represented in the graph. So in the graph, the elevated LPA had more TBR for looking at the left carotid, and the same findings in also looking at the aorta. And if you look at the diagram DEF, they labeled peripheral blood mononuclear cells and then examined at 6 hours post-infusion, and they represented this as arterial wall to blood pool ratio. And in this, you can see from 3 hours, 4 hours, 6 hours, those with normal LPA, after they were injected with this and labeled mononuclear cells, their ABR didn't change much. But for those with high LPA, it went up. This probably suggests that in individuals with elevated lipoprotein little a, they are more likely to have arterial wall inflammation. and acute phase reactants, which are like the downstream effects of inflammation. So if you look at LPA, several longitudinal studies, like large cohort studies, have looked at LPA and CRP. So over here, we have 3 of the big trials in this review paper. So the Copenhagen population study, which had a mean follow-up of 8.1 years, they noticed that over time, patients with high and individuals with high LPA and high CRP had the highest risk of cardiovascular events. If you also look at the MESA study with a 13-year follow-up, individuals with high LPA and high CRP greater than 2 milligrams also had a higher risk compared to those with low CRP. And the accelerator cohort 2 with a follow-up of 2.5 years, again, we noticed that LPA was related with a higher risk in those with CRP greater than 2 milligrams. This suggests that LPA effect is probably mediated by CRP, or they together are able to potentiate CRP potentiates the effect of the atherogenic effect of LPA. And so knowing that it has such it's so intertwined with inflammation, and we want to know lowering LPA levels and which drugs would actually affect inflammation. And this on the panel up here, we can see, looking at PCSK9, we know PCSK9 inhibitors are able to decrease LPA levels by up to about 30%. However, these 2 studies, when they looked at its effect on arterial wall inflammation, it wasn't significant. But the newer drugs that are currently being studied, looking at ApoA antisense therapy, they also were able to decrease LPA. However, when you assess arterial wall inflammation, there was a significant reduction. And so this suggests that probably lowering LPA may be enough, or perhaps you need drugs that will not just lower LPA, but it's also able to target the inflammatory cascade or the inflammatory processes that LPA induces. I have 2 here of the 2 leading trials right now looking at LPA lowering therapies. There's so many of them currently in phase 2 and 3 trials. But the main one is probably the Horizon trial, which is an antisense against ApoA. And in these individuals, they are injecting them with 80 milligrams monthly versus placebo. And their outcome is established DVD. And this will be the first study to look at the effect of lowering LPA and whether that's reducing these levels actually translates into reduced adverse cardiovascular events. So I think they're probably going to result in a year or 2. So we're all anticipating what the results here will show. We also have an olpasiran trial, also looking at this is small interfering RNA. They're in phase 3, and the initial results have been remarkable. Excuse me. We've seen percent reductions of about 70 to 100%. So knowing all this, there are still several unanswered questions that we have. Will reduced levels translate into reduced cardiovascular risk in randomized placebo trials? And which standardized assays should be used globally? And should there be a threshold for treatment? Or because, as we said, we still don't know if it plays any physiological role or it doesn't. So just reducing it to 0, is that enough? Or should we be reducing it to a certain level? And should future therapy target all persons with elevated LPA irrespective of their demographics? And perhaps more importantly, should a subset of people with added risk, perhaps individuals in persistent inflammatory states, be started on therapy irrespective of their ASCVD risk? And in risk stratification, should we have cutoff for different races, knowing that some ethnic groups have higher baseline levels? And given its bidirectional relationship with CRP, is there a role for anti-inflammatory agents in therapy, or is just reducing LPA enough to curb the pro-inflammatory effects? And so this is what I'm partly going to be studying in my research project for the year. So my project is evaluating the effect of chemotherapy on lipoprotein little a in cancer patients, and it's a post-hoc analysis of the PREVENT trial. So we know cancer survivors have an increased cardiovascular disease, and this remains the leading cause of non-cancer related mortality, accounting for almost 25% of deaths in patients over 50 years. And we know LP is augmented in subpopulations with chronic inflammation, and oncogenesis in itself, it's an inflammatory state. And among cancer patients, we know anthracyclines are probably the most cardiotoxic. Their mechanisms include direct cardiotoxic effects, but there's research to suggest that they probably induce endothelial injury and plaque formation. And if these two are contributes, then these are driven by lipids and inflammation. And so, despite the fact that we know that there's an increase in cancer survivors, there are lack of suitably designed randomized trials in this space to determine what screening tools and intervention actually work. And so our aim is to investigate the effects of anthracycline therapy on lipoprotein(a) levels in cancer patients, knowing that LPA is mainly produced in the liver, and so anthracyclines may affect its concentrations not only through induction of inflammation, but perhaps through liver injury. And also we want to assess the levels of lipoprotein(a) and the steroid inflammasomes prior to the induction of anthracycline, and also to determine distinct changes in the steroid inflammasomes post-chemotherapy. So our methods here will be using samples from the PREVENT trial. And the PREVENT trial is a double-blind, placebo-controlled, 24-month randomized trial of 40 milligrams of atorvastatin per day that was administered to patients with breast cancer and lymphoma receiving doxorubicin. It was conducted within the National Cancer Institute Oncology Research Programs across 31 states. Unfortunately, the results, it didn't show any significant difference in patients who received statin versus placebo. However, we have serum from these patients still there, so we figured, why don't we use that to assess to answer our research question here. So we in our study are not particularly interested in whether a patient got atorvastatin or placebo, because we know from trials that statins do not significantly increase and decrease LPA, and even some studies suggest about 5 to 10% increase in LPA. So, but for these patients who are seen at baseline at 6 months and at 24 months, we're going to assess at each visit their LPA levels, their lipid levels, interleukin-6, and then the steroid inflammasomes. And as I said again, the significance will be to provide novel insights into the residual impact of lipoprotein(a) on cardiovascular disease in this population. And we want to assess the time-varying effects of chemotherapy on lipoprotein(a) levels in cancer patients who we know are at an elevated risk of cardiovascular disease, and whom we also know are in a state of inflammation given the oncogenesis and all the drugs that they receive. So in conclusion, we know LPA can trigger several inflammatory pathways. IL-6 is associated with elevated LPA levels, and we know inhibition of IL-6 results in decreased LPA levels. We know oxidized phospholipids of LPA are a major contributor to the atherogenicity of LPA, probably the most contributor. And then we know LPA and CRP may jointly predict CAD risk. And also elevated LPA is an important driver of excess cardiovascular risk in a subset of patients. And these are patients with inflammation, patients with premature ACVD, families with premature ACVD. And so these are subsets of patients that, given that we know LPA is so pro-inflammatory, might actually benefit from treatment, and we should probably be assessing how LPA affects their cardiovascular risk. And future clinical trials would potentially assess cardiovascular efficacy of anti-inflammatory and LPA lowering combination therapies. I saw this article that was written by the New York Times. It's about 3-4 years old, and it was titled "The Heart Risk Factor Even Doctors Know Little About." It's funny, but if you think about it, it's actually quite true, because this paper published in the American Society of Preventive Cardiology, even though we know LPA is so atherogenic, out of the secondary ACVD prevention cohort, only 1.2% of them get their LPA tested. And in the primary cohort, we get only 1.3% tested. And on the right side, if you look, Black patients, 24 of Black patients who had their LPA tested, about 24.5% of them had elevated levels. So this is just to urge us all and remind us to remember to check LPA levels, especially in individuals that we know are at elevated risk or have some residual risk of atherosclerosis. So I would like to conclude by saying a very big thank you to my research mentors, Dr. Mehta, Dr. Botino, and Dr. Salum, for the incredible support and direction they've given me. I also like to say a big thank you to the Pauley Heart Center T32 Fellowship Program for the opportunity to be able to conduct research during fellowship, and Dr. Hanley, Dr. Kalahasti, and also to the staff of the Pauley Heart Center who are always willing and ready to help. I'm grateful. So with that said, thank you for your attention, and I'm happy to take questions.
Pamela, quick question for me. This is Dr. Hunley. In all of the studies that you worked through today, highlighting the risk of a variety of cardiovascular events associated with elevated lipoprotein (a) levels, how many of those accounted for other risk factors in that particular patient population, meaning, for example, LDL levels or the presence of hypertension or diabetes? I just wonder, have you sub-selected? It didn't seem like there were adjustments that were presented in any of those data. It was sort of univariable associations.
Yeah, thank you for the question, Dr. Hanley. It's actually a very good question. But even though I didn't present most of the other the methodologies of some of these studies, most of them actually do account for LDL, because we know in everything we always want to know how LPA relates to LDL. So they actually do account for that, and these are adjusted for most of the confounders that we know, hypertension, diabetes. So the LPA studies in most of the cohorts, the MESA, the Copenhagen study, they all looked at baseline risk factors, cardiovascular risk factors, as well as LDL. And most of these, they found that it was an independent risk factor for instance, in the CRP study, was an independent risk factor for MACE after accounting for all these other potential confounders.
Very nice. And just a quick follow-up question. In those with elevated lipoprotein (a) levels, has there been the incorporation of, for example, CT scanning, coronary calcium, or even CTA that further risk stratifies you to low, intermediate, or high risk if we know already that you have an elevated lipoprotein (a) level? And maybe it's another test beyond CT.
Yeah, that's another great question. I'm not quite sure on that. In my reading, I didn't really come across it, probably because I wasn't looking at the imaging effects of more looking at the interleukins and the CRPs. But I think it will probably be a great study to conduct, just to see how CTA and high LPA, how it correlates with plaque formation, and perhaps there are studies there, but I'm not quite sure.
That might be a project the two of you could work on
Yeah.
together.
Yeah, I think in the MESA study there is LPA and calcium score has been studied, but I don't think the CTA or CT angio has been applied because MESA didn't have CT angio, but yeah, we can do CT angio, and that would be a very interesting thing to look.
Well, great job today.
There's a question in the chat from Dr. Burns.
Yes, so Dr. Ben says, enjoyed your talk. Wonder if VCU Health can get behind getting all of our patients checked for LPA. Thank you, Dr. Benz, for the question. But I think that's the goal, right? For everybody to have their LPA checked. And because as I said, it's a genetic marker, and you could potentially identify people whose family members would also benefit from checking. But yeah, I agree. We should probably be checking LPA more often than we do now.
Okay, so we're right at 8:30. If there are no more questions, we'll go ahead and wrap up. Congratulations and thank you. That was wonderful.
Thank you.
Thank you.